Hello everyone, Hafiz here from Axiom. I'm joined by my colleagues Andrew Hong and Wujia Ali. Super excited to have our panel today to discuss emerging MOAs in heme malignancies, as well as new advances in multiple myeloma and lymphoma. Today we are joined by Dr. Michael Dickinson, Dr. Rajay, Dr. Moti, and Dr. Fowler. It is pretty early in the morning. It's 2 a.m. in Melbourne, Australia time, so thank you so much, Dr. Dickinson, for joining us. Dr. Rajay, calling in from Mass Gen, thank you for joining. Dr. Monti from Paris, as well as Dr. Fowler, who's on his family vacation, so really appreciate you joining us in the middle of a summer vacation day. Please use the Q&A function to ask your questions, and I'll hand it over to Dr. Rajay to moderate the session.
Thank you so much, Hafiz, and this is it's a real honor and a pleasure to be on this town hall today. As you just heard, I'm joined by a really international stellar faculty. We have Dr. Fowler from the MD Anderson Cancer Center, who's going to focus on lymphomas. We have Dr. Michael Dickinson from Melbourne, all the way from Melbourne, and we have our favorite Dr. Moti from Paris. So we're in for a treat. We'll start off with myeloma, where Dr. Moti will talk about practice impacting data in myeloma and amyloid. I'll talk to you a little bit about BCMA targeted approaches, and then we'll go into indolent lymphomas, the standard of care, and then talk about some of the novel agents. So please feel free to keep the Q&A session going, because we are going to pay attention to that, and we're going to try and get to as many questions as we can along the way during this town hall. So with that in mind, we're going to go ahead and we're going to start off with Dr. Moti, who's going to be talking to us about practice impacting data in myeloma and light chain amyloidosis.
Thank you very much, Dr. Raji, for the kind introduction. Hi, everybody, and good morning, good afternoon, good evening, wherever you are. It's a great pleasure to be part of this nice educational activity. I've been asked for the next few minutes or so to address some of the most recent data in the field of multiple myeloma. And I must confess, this can take us hours, days, even weeks, because there's always something new in myeloma every other day. So because of the limited amount of time, I needed to make a strict choice. So you can see on the slide, the focus is going to be on 3 important trials, in my opinion. One in amyloidosis, because this is going to be practice changing. This is the so-called ANDROMEDA trial that was a plenary talk at the EHA meeting. This is a randomized phase 3 trial comparing the so-called CyBorD or VCD, if you prefer, versus an experimental arm adding daratumumab subcut. So the idea is to see whether adding the monoclonal antibody anti-CD38 is going to provide any added value and benefit in newly diagnosed AL amyloidosis. And this is extremely interesting because this is a relatively rare disease where I'm not aware of any drug being approved actually in amyloidosis. And 20 years ago, the outcome of this disease was awful, especially if there is heart involvement. But today, when we look to the results from the ANDROMEDA trial, and actually they have chosen the CyBorD as a standard of care because this is really a very potent, very effective, well-tolerated regimen, I think widely used across the globe because bortezomib is now very popular. Cyclophosphamide is there since more than half a century, and dexamethasone. And you can see the study design, very straightforward, very simple. just comparing VCD versus DARA VCD. And you can appreciate there is a very significant advantage in terms of overall response. The primary endpoint was about hematologic CR, and I don't need to spend hours to highlight this impressive difference between the daratumumab-based combination versus the current standard of care. And most importantly, when you look into the major organ deterioration, because we know very well that organ involvement is going to have a significant impact in these patients on their final outcome. When you look to the multi-organ deterioration PFS, again, you can appreciate a very elegant difference in favor of DARA subcut versus CyBorD. And all of these positive results are achieved actually with, I would say, relatively acceptable toxicity, nothing new, nothing special compared to what we already know actually from the different daratumumab studies and daratumumab combinations. So to make a long story short, my simple take-home message here, it is probably that in the very near future, and I'm sure some colleagues have already started using this, DARA-CyBorD is going to be the preferred treatment choice in newly diagnosed AL amyloidosis.
So I'm just going to stop you there, Mohammed. Obviously, the ANDROMEDA data is really remarkable data, and for the investigators to do a nearly 400 patient study in a randomized fashion in this otherwise very rare disease in itself requires a lot of credit. We know that daratumumab is very, very active. One of the questions here, we've used VCD as a standard arm, and the question really is, can we get away by getting rid of Cytoxan, and will we ever consider doing something like a Velcade-Dex daratumumab arm, and what are your thoughts around trying to get rid of chemotherapy in this context?
Well, this is a great question because obviously we would all love to get rid, I would say, of the old-fashioned middle-age style therapy like cyclophosphamide. Nevertheless, we know very well that in AL amyloidosis, alkylating agents play an important role, and this is, you may remember the New England Journal of Medicine paper by Jacquard and colleagues from the French group, showing, for instance, that melphalan dexamethasone is really an important combination. So I believe alkylating agents are probably here to stay here. Having said this, it doesn't mean that at some point we cannot skip the cyclophosphamide, maybe challenging the patient with 2-3 cycles of CyBorD with daratumumab, and at some point, depending on tolerance, you may wish to skip this if there is a good reason to do so. I doubt, because you highlighted it, it's a very rare entity. It is unlikely, in my opinion, that someone will jump in and do a study, another randomized trial, skipping cyclophosphamide. Unlikely to happen.
Another question to you from the audience, Mohammed. We now have the subcutaneous formulation of daratumumab, and specifically in this patient population, do you see that as a benefit, folks with cardiac failure and renal failure?
Yeah, absolutely. I think daratumumab subcut is a true advance in the field. And it's really making the life of our patient easier. It is approved, by the way, already by FDA and EMA. It's making the planning and scheduling in our ambulatory care clinic easier. And we do have, I think, robust data, and this is why it has been approved, showing that it is equivalent to the IV formulation. And if I remember well, in the Columba randomized trial, even the safety profile of the subcut was slightly better than the IV. So I think we can be quite confident about the subcut formulation in these patients.
Great, thank you.
Should we move to the next one?
Yeah, I think so.
Okay. Well, the next choice is about this IKEMA, so-called IKEMA trial. And again, it has been presented as a late-breaking abstract at the EHA meeting. This is a phase 3 international randomized trial comparing an already approved combination, KD, carfilzomib, dexamethasone. And you may remember this is the so-called Endeavor trial, which compared KD to VD and could show the superiority of KD to VD. The question here, and this is really a crucial and very important question to all of us, and which is going to be useful for many, many patients, is about addition of isatuximab. So I have just mentioned daratumumab. So isatuximab is the new player, I would say, in the field of antibodies against CD38. And by the way, it's already approved in combination with pomalidomide and dexamethasone in relapse refractory myeloma. So here we have a very straightforward design comparing the doublet KD, carfilzomib, dexamethasone, to a triplet, isatuximab KD. And this is in relapse refractory myeloma. And this is extremely important because, as you may guess, we're tackling here, we're using a combination which is going to be extremely useful in those patients who are IMiD refractory, especially lenalidomide. And it has been clearly an unmet need because these days, many, if not the majority of our patients are receiving lenalidomide continuously. So at some point, they become resistant, refractory to lenalidomide. So how can you salvage them? And here you have a very nice answer. You can see the primary endpoint. This is about the interim PFS. And again, this is a remarkable curve in favor of the triplet isatuximab KD versus KD. And you can appreciate, even we're talking about a relapse disease setting, some patients, a significant proportion of patients are able to achieve MRD negativity. So MRD negativity is not exclusively now related to the frontline. Even in the relapse setting, you can achieve this very nicely. What about the safety profile? Because obviously, we always question the use of carfilzomib when it comes to some cardiovascular side effects. We know that antibodies do have some infusion-related side effects, especially during the first infusion. But here, at the end of the day, actually, this combination is relatively very safe, very well tolerated. So when we put together this study, IKEMA, isatuximab KD, and we put together the Candor trial, which has just been published actually 2 days or last week, I think, a few days ago in the Lancet by Dr. Usmani and colleagues, where we used daratumumab, carfilzomib, dexamethasone versus carfilzomib, dexamethasone. We do have in hand now, and hopefully they will both be approved soon, we do have a wonderful combination, especially in patients who are lenalidomide refractory. So adding an antibody against CD38 using a second-generation proteasome inhibitor plus dexamethasone, this is a very good answer to those patients who are in relapse refractory myeloma resistant to IMiDs, especially to lenalidomide. And this is going to be practice changing, in my opinion.
This was a really nice summary, Mohammed, and absolutely, we need to have non-IMiD containing regimens. I also appreciate the fact that you brought up Candor, and if you look at the IKEMA and the Candor data, although they look fairly similar, the IKEMA study looks a little bit better. Do you have any sense of why that is? And you do have a question from the audience as well, wherein they want you to put into perspective a little bit in terms of CD38 directed treatments and what happens with versus panobinostat based treatments. So if you want to address both of those quickly.
Okay, well, I have been always taught by statisticians that we should be extremely cautious about comparing across trials, because this is not scientifically relevant. Obviously, from a visual point of view, one would say, well, the PFS curves in IKEMA are higher or nicer than Candor. However, I think it's more about the hazard ratio. It's more about how is your comparator, your control arm is doing. And the control arm here is doing better in IKEMA than in Candor. Obviously, these are the first results. We really need to wait a little bit until we have more matured, more follow-up. At this stage, my gut feeling is that both options, DARA KD, isatuximab KD, would be really great options for those patients who are IMiD refractory. Now, your question is about, is there any role in this story for panobinostat, which is jumping in here, It's an interesting question. We know panobinostat is approved in combination with bortezomib dexamethasone. I believe the results of panobinostat have been a bit controversial in the community because some gut side effects, diarrhea. So for the moment, I think what we have in hands, combining an anti-CD38 plus a proteasome, second generation proteasome inhibitor, is really providing some very great results. And I mean, we participated, for instance, to this trial, and I can assure you, it's absolutely amazing how these patients are doing and tolerating this combination.
Yeah, I think I would just add, the drugs like the HDAC inhibitors and panobinostat, although approved, because of the toxicity profile and because of everything else we have available to us, we're using it less and less. And I think the role for those drugs is, we have to revisit those or maybe find drugs which are better tolerated. There is a quick question on Rev-sensitive patients. What would you consider IKEMA, Candor, or Pollux? And the answer to that is really, the good news is I think we have choices now. And because we have choices, looking through the patient profile, the good news, when you combine with a proteasome inhibitor like carfilzomib, since we have DARA approved, and the subcutaneous version, it's an easy combination, the subcutaneous with carfilzomib. The carfilzomib isatuximab combination is also a good combination because ISA can be given over a shorter duration of time. So either or are perfectly reasonable combinations, and I don't think we can say one is better than the other. I think, right, Mohammed? Would you agree?
Absolutely. I'm fully in agreement with what you said. Obviously, again, it's very difficult to compare between these trials. These are different populations in general. The trials were not performed at the same time, and the landscape keeps on moving. Having said this, obviously, if we have a patient who is still sensitive to lenalidomide, well, this is where you have a wide panel of choices, and you have, I think you would expect some good results and good outcome, irrespective of the combination. I mean, when we look to the Pollux results with long-term follow-up, the PFS is really impressive. Again, I wouldn't hesitate to use Dara Revdex in these patients, but if I use Dara KD or Cetuximab KD for some reason, you know, I don't know, allergy to lenalidomide, it can happen, or sometimes patient observance and you prefer to bring them to the hospital for the infusion, well, definitely these are available options. And it's going to be more and more, I think, once all of these drugs and combinations are approved, this is where we're going to touch base with personalized medicine, and where you can factor the patient characteristics, the medical history, the disease characteristic, the treatment history, and putting all this together, we may end up with a nice equation about saying, well, I prefer to go to Pollux, I prefer to go to Candor, I prefer to go to IKEMA.
Great. Thank you so much, Mohammed. With that, we'll go into your next one.
Absolutely, please. Next one. Yeah, okay. So this is an interesting study. I don't believe it's going to be practice changing today, but I thought that the choice of this study for me is about an unmet medical need. And I think in the myeloma field, we've been struggling, and we are still struggling with the outcome of high-risk cytogenetics patients. I think we have made amazing improvements in multiple myeloma, and the standard risk myeloma today, if you give them induction with Dara-VRd, auto-transplant maintenance, you would expect these patients living more than 10 years or even 15 years. And at time of relapse, they can be salvaged effectively. When it comes to the high-risk cytogenetics, when it comes to the deletion 17p, for instance, and I have seen such patients earlier this afternoon in my clinic, actually, we have slightly improved, but we are still really lagging behind, you know, the standard risk cytogenetics. And this is why one would like to put together all the effective, great drugs we have in hand. And that is the spirit of this so-called concept trial, looking into adding Cetuximab, the same anti-CD38 antibody, to KRD, carfilzomib, lenalidomide, dexamethasone. So in other words, one would say, well, okay, I have a high-risk cytogenetics, very difficult, hard to treat. I'll use my best antibody, an anti-CD38. I'll use my best proteasome inhibitor, carfilzomib. I'll use my popular and good IMiD, lenalidomide. And what does it do? Well, actually, this is a phase 2, of course, 50 patients. That's not so bad, I would say, for high-risk cytogenetic, because they're not the majority of patients. And you have an overall response of 100%. So it's a good start. And when you look into the results, actually, VGPR is already very good in these patients. And we have patients who are already MRD negative. And this is extremely important because we believe, and there is a publication, for instance, from the IFM, showing that MRD negativity during the course of the disease may, at least in part, overcome the bad prognosis of high-risk cytogenetics. So this is why, at some point, validating this quadruplet combination in the high-risk cytogenetics may be extremely useful, especially that it doesn't harm stem cell collection, and these patients will be able to proceed to auto-transplant. So I think it's a very good teaser to say that maybe now time has come to test these very powerful, very strong combination in high-risk cytogenetics, in addition to high-dose chemotherapy, because we know they also benefit from auto-transplant. And if I want to be provocative with a US audience, for instance, I would even advocate double auto based on the Lancet Hematology paper from a couple of months ago, published by Dr. Cavo and colleague from the European Myeloma Network. So I think this is a very optimistic message, I think, for the community, that maybe the high-risk cytogenetics is moving into favorable outcome in the near or midterm.
I think you are absolutely right. I think the important takeaway for me, at least in the high-risk patient population, is depth of response is extremely important. And this is where I do believe MRD testing and trying to get to MRD negativity and continuing to maintain people MRD negative is absolutely critical. And now that we have 4-drug platforms, this is the perfect place to test them. And when you have patients who are transplant eligible and ineligible, you can begin to ask that question of how much does the transplant add to the depth of response with these 4-drug combinations. So a lot of work going on with 4-drug combinations. The ISA-KRD is one example. We've seen data from the Cassiopeia study, and we've also seen data from the Griffin trial. So 4-drug combinations are certainly here to stay and take on a completely different significance in the high-risk patient population. So I'm going to move on to the next part, Mohammed, in the interest of time, because we do have to talk about lymphomas as well. What I am going to do in the next few minutes is going to talk to you all about BCMA targeting agents in myeloma. And there is a question out there in terms of different BCMA approaches and which one would be the best. And before we address that question, let's just look through some of the data, because as you see out here, what we've highlighted is the DREAM2 data, the teclistamab data, and the Karma and the J&J data. So you're going to get a flavor of BiTE, you're going to get a flavor of a conjugate, as well as some of the cellular therapies, and we can parse out the data after. So can I have the next slide, please? So this is the DREAM2 data, and this is the data with belantamab mafodotin, wherein we just had an ODAC meeting just a couple weeks back, and in fact, overwhelmingly, everybody in the Oncology Advisory Committee voted in favor of belantamab. Belantamab is a conjugated antibody which is directed against BCMA, as you all are aware, and it uses the MFA as the toxin warhead in this case. And what DREAM2 did was studied it in 2 different doses. You've seen data with DREAM1, which is already published, where belamaf was used at a single dose of 3.4 mg per kg. And in that setting, we saw an overall response rate of 60% with a duration of response of about 9 months. Now, this is DREAM2, which is a subsequent study wherein they've compared 2 different doses of belantamab mafodotin, 2.5 milligrams per kg or 3.4 mg per kg, with the idea of attenuating some of the toxicities associated with belantamab. One of the toxicities associated with this class of drugs is ocular toxicity, so that keratopathic events are seen in a significant proportion of patients. About close to 50% of patients will see some corneal toxicity associated with these conjugated antibodies. If you look at the overall survival or even the response rates of whether you got 2.5 mg per kg of belamaf or 3.4, really no difference in terms of response rates, maybe a slightly better response rate with a higher dose, and survival was not any different. The 2 toxicities which I do think are worth highlighting is, one is the thrombocytopenia, and the second one is the ocular toxicity, which I've already alluded to. And that ocular toxicity did not change whether you got the lower dose versus the higher dose. So this is something which I do think we all have to be thinking about going forward when it comes to conjugated monoclonal antibodies. And we are going to have to try and figure out what the best sort of dosing schedule with these antibodies is. Clearly an effective regimen. And the other thing I do think we need to highlight between DREAM 1 and DREAM 2, the reason that the response rates have gone down to about 32, 34% in the DREAM 2 study is a very different patient population. Most of these patients were exposed to a CD38 monoclonal antibody, and most of them were in fact refractory, quad refractory patients who were refractory to a CD38 monoclonal antibody, which was not the case in DREAM 1. So even so, the response rates have gone down significantly, but a very different patient population. And I think the big thing here is to deal with, try and figure out how we can overcome some of the toxicities, mostly the ocular toxicities that we see with this. But nonetheless, a very active agent. And the other nice thing about this conjugated antibody is it's easy to combine with some of the other backbone drugs that we know. And some of that data was presented at this year's ASCO as well, where bortezomib has been combined with belimaf in one of the DREAM, I think it was DREAM 7, which has been presented by Dr. Nuka. So we can go over all the BCMA and then we can talk about discussing it some. So I'll go to the next slide here. This is the duo antibody. This is teclistamab. This is a phase 1 dose escalation trial, a classic phase 1 design where we started off with very low doses and went up. And once you get to dose levels of more than 38.4, you start seeing an overall response rate of 30%. And once you get to 270 micrograms per kg, you actually see an overall response rate of 67%. What this is a duo antibody which is targeting BCMA on the one hand, and it also targets CD3 and activates CD3, which is your T cells. So in essence, this is an antibody which targets BCMA, so targeting your tumor cell and activating T cells to do the job of the T cells and cause killing of the myeloma cells. What you see out here is responses in patients who are getting the sort of efficacious doses of this antibody. You do see toxicity also. Most of the toxicity is very similar to what you see with cellular therapy as well. You see cytokine release syndrome. You can end up seeing neurotoxicity as well. But with this specific duo antibody, the CRS rates were actually extremely manageable, and most of the CRS seen with this duo antibody was about grade 2, with very little grade 3 and almost no grade 4 CRS seen with this. What's also quite remarkable here is the duration of response, and you see that as you get to higher dose levels of teclistamab, you're seeing improvements in responses over time, so that you're starting to see MRD negative disease also in a subset of patients, and with over time, hopefully this is going to improve. So this is just an example of one of the duo antibodies. There are a bunch of other BiTEs which are in clinical development in the context of myeloma. And in the BCMA space, I think this is another addition in terms of targeted approaches to BCMA in multiple myeloma patients. So I will move on to the cellular therapy, and then I will take there's a bunch of questions out there on DREAM. There's a bunch of questions on BiTEs as well, but why don't I address them after I just go through the data with the CAR T cells as well. So the other important piece with BCMA-directed approaches is cellular therapy, obviously, and the one which is furthermost in terms of development is the ide-cel data. You saw the ide-cel data presented at this year's ASCO, and this is probably one of the largest studies in myeloma with cellular therapy, wherein Dr. Munshi presented on 128 patients. The good news is all of these patients were able to be given treatment, and as you got to 450 million cells, the overall response rate in this patient population was north of 80%. This translated into an overall survival and the progression-free survival was about 9 months with an overall survival of close to 19 months. If you look at the target dose, which was 450 million cells, and saw patients who achieved a complete response with ide-cel, those patients had a progression-free survival of 20 months. Now remember, these were patients who had had at least 4 lines or more of treatment, and most of them were, or in fact all of them were refractory to their last prior line of treatment. The majority of patients had seen both IMiDs, both proteasome inhibitors, and in fact all of them had seen the CD38 monoclonal antibody. So a really difficult patient population to treat. And there is the experience from the Mammoth trial, which has looked at this database, wherein on an average, these patients live for about 9 months, and their PFS to whatever you give them is less than 3 months or so. So at least this data is quite encouraging and quite remarkable in this context. Moving on to the next one here is the CARTITUDE trial, or the J&J CAR T-cell product, J&J 4528, again used in the same very relapsed refractory patient population. The difference between ide-cel and J&J 4528 is 4528 targets 2 epitopes of the BCMA. We obviously see very high response rates, with the majority of patients actually responding to this BCMA CAR T-cell product. The CR rate in this patient population was close to 85%, with an overall response rate of 100% with MRD negative disease as well. The follow-up with the CARTITUDE study is a little bit shorter, so we just have to wait a little bit longer to see what the progression-free survival turns out to be. But at 9 months, I believe about nearly 26 of these patients remained progression-free survival at 9 months. So we do need a longer follow-up on this. I'm going to quickly try and address some of the questions which have come along in the BCMA space. One of the questions was, when we have so many different approaches targeting BCMA, which one is going to work out to be the most efficacious? Well, you know, that would take a full hour of a discussion, so I'm not going to belabor that. But I think the important thing to know is we have different choices here. We have some which are off the shelf, some which are more sort of focused on trying to develop in terms of the cellular product. And end of the day, I do think going forward, we are going to be using all of these approaches probably in some kind of sequencing approaches, either bridging or as part of maintenance, whether you start off with a CAR T-cell product and follow it up with a conjugate or not is something which we could think about. With that in mind, I think we will move on quickly to Dr. Fowler, just in the interest of time. Dr. Fowler is going to go over some of the new and relevant data with the lymphomas now.
Thanks, guys. Can you guys hear me?
Yeah.
Okay, great. I'm getting a connection unstable message, but so I'm going to assume, let's keep going. Next slide. If someone on the panel will just let me know if you lose me.
Yeah.
So, great. The first one, so EHA and EHA was pretty exciting. Yeah, we said some, I picked about 4 abstracts that I thought were relevant, either because they could potentially affect the current standard of care, or because they represent a couple technologies that will soon be in the clinic. And the first one was the GALLIUM trial. So folks may remember this is a phase 3 trial of essentially chemotherapy looking at two different antibodies. I think everybody knows that rituximab is the kind of the current standard of care that we combine with pretty much everything in low-grade lymphomas. And this study was looking at whether there was a benefit of using a newer version of CD20 therapy called obinutuzumab. In this little diagram, G means Gazyva, which is the commercial name for obinutuzumab. So pretty simple design. Took previously untreated follicular, randomized them to get chemotherapy with either obinutuzumab or rituximab. And the primary endpoint here was to look at progression-free survival differences between the arms. And you could see that with long-term follow-up, there was a significant difference, as well as both in progression-free survival and time to next treatment. And this is really honestly not that much different than what we had seen with the first presentation, where there was a separation between the curves. Now with longer follow-up, there is still no difference in overall survival. So 5-year overall survival here looks like pretty much identical, 90% versus 89.4%. So what does this mean to me? I think that if you believe that obinutuzumab adds benefit, this gives you ammunition. So good, it prolongs your remission. If you did not believe in obinutuzumab, it gives you ammunition. So I think that, again, with no difference in overall survival, there was increased side effects with the obinutuzumab arm, mainly more infusion reactions, more neutropenia, more infections. And how that, how you adjust, I guess to say how you weigh that, again, I think it depends on, like a lot of patients in follicular lymphoma, we always want to discuss your goals of care. Longer PFS, but no benefit in overall survival. So I think some patients who are using obinutuzumab in the second line, this would further justify that decision. Next slide. The MAGNIFY trial is another study that we saw some longer follow-up. Now, just to remind folks, this is an ongoing trial that has two arms. The first arm looks at using lenalidomide and rituximab, or R squared, and these are all patients with relapsed and refractory indolent lymphoma. Everybody gets R squared. Then they are randomized, if they at least don't have progression, so essentially stable disease or better, to either receive lenalidomide or rituximab as maintenance or rituximab as maintenance. Again, to remind everybody that doesn't do a lot of lymphoma, rituximab maintenance is one of the standard of cares for folks with relapsed disease. So this study is essentially looking at, is there benefit of lenalidomide added to standard rituximab maintenance? They dropped down the dose of lenalidomide. I think this is important. In the induction arm, only 20 milligrams. In maintenance arm, drops to 10 milligrams. So if you do ever use this in clinic, don't use prolonged 20 milligrams. It's associated with a lot of cytopenias. We saw long-term follow-up. I shouldn't say long-term follow-up. These are follow-up of the, I guess, interim analysis, showing that, not surprisingly, there was higher rates of adverse events in patients who had lenalidomide and rituximab compared to rituximab alone. At the median progression-free survival, this looks fairly similar. I should say, so this is all patients, as well as follicular lymphoma and marginal zone lymphoma. I don't think we have it in this slide, but one of the things they looked at in this group was the outcomes in patients that had high-risk disease. These are patients that progressed within 24 months, or patients who were refractory to rituximab. And it looks, importantly, that lenalidomide and rituximab was very effective in these groups. We saw over 50% response rates in both of those groups, along with, as you can see, pretty significant progression-free survival. So this interim analysis, I want to just kind of clarify, is really only looking at the outcomes of the induction arm. We don't yet have long-term follow-up to look at the two different maintenance arm. What I take out of this, lenalidomide rituximab is active in a second-line setting or the third-line setting, especially in patients with high-risk disease. With progression-free survival, not that bad. You can see that the PF, the median, is around 2 years. To remind folks of the currently approved agents, like some of the PI3 kinase inhibitors, those have around a 1-year progression-free survival. So again, as one of the earlier abstracts pointed out, we shouldn't compare across trials, but it looks like at least in relapse disease, pretty long progression-free survival. Next slide.
So
including
before you move on, Nate, just a
Talk
quick
to me.
question on the GALLIUM trial.
Sure.
Which you so nicely showed, not a lot of difference between obinutuzumab and rituximab. Is there a specific patient population that you would consider obinutuzumab? Specifically when you're talking about higher toxicity also associated with obinutuzumab?
So I should tell you, I personally do not use obinutuzumab in the frontline setting in the vast majority of patients. But I think there are kind of two schools of thought with follicular lymphoma with regards to induction regimens. I think that unless I can see an overall survival benefit, I tend to save a lot of the strategies like maintenance as well until patients relapse. The main thing about follicular lymphoma is that patients have very heterogeneous outcomes. So for example, we know some patients can get induction without maintenance and never relapse. Other patients can get rituximab alone and never relapse. So I generally err on the side of giving less toxic, less aggressive therapy as my first line of therapy. And then wait to see how patients do. And I kind of use that same philosophy when I'm thinking about obinutuzumab versus rituximab. If I can get away with rituximab only, and potentially get this patient in a 10-year remission or never relapse, I'd rather save obinutuzumab for second line or third line setting. So that's a long answer to your short question. I think that in generally I tend to give it in all patients, and I save obinutuzumab for the second line. But I think that using it in high-risk patients in the first line is not wrong. And I think if you surveyed a lot of people around the U.S., you'd probably get a 50-50 split on that answer.
Got it. Thank you.
Yeah.
And the MAGNIFY is just mostly proof of concept, I think, that consider using lenalidomide-based combinations.
Exactly.
In your high-risk patient population, but not so much in the marginal zone lymphomas, right?
Yeah, so marginal zone, and we had seen this in the phase 2 trials, and in the phase 3 trials with R-squared, that marginal zone lymphomas are probably the least likely to respond. In fact, when I was running a lot of the early phase 2 trials, I often used to joke I could predict the histology just by looking at the imaging. So when I was doing tumor measurements, when I saw these patients that were slow responders, almost to a patient, they were marginal zone lymphoma. Follicular lymphoma is very dramatic responses early.
Great, thank you.
Yeah. Good. And then next slide. So ASPEN trial. So I went off on a little bit of a side road here. I picked Waldenstrom's. This is, as you know, one of the indolent lymphomas that is obviously less common in clinic. But I picked this because it's one of the first randomized studies to look at the outcomes of 2 different BTK inhibitors. So in this study, they, again, took patients with Waldenstrom's macroglobulinemia, and they randomized them to receive I want to look at the top here. This is the top arm. That's where the bulk of patients were. These are all MYD88 mutated patients. Randomized them to receive zanubrutinib, which is a kind of a next generation BTK inhibitor, or ibrutinib. About 100 patients in each of these arms. If you focus on that group, again, I'm just really going to focus on this top cohort 1. The outcomes look fairly similar. If you look at the overall response by intent to treat population, they look pretty similar, maybe a little bit higher with VGPR rate with zanubrutinib. The other outcomes are all fairly similar. So I think that, again, for me, they look about the same, no statistical difference in the response rate, maybe a little bit deeper response with zanubrutinib. But what I thought was more important was the adverse event profile was different between the two. We saw that there were higher rates of atrial fibrillation, higher rates of bruising in patients that had ibrutinib compared to zanubrutinib. Overall, the adverse event rate with regards to grade 3, greater than grade 1, were fairly similar. But I think, especially in the older population and in the patients who often receive these BTK inhibitors chronically for many, many years, looking at these kind of side effects like AFib, bruising are very relevant when we're thinking about picking one treatment versus the other. Progression-free survival, again, for me, these either may be a little different, but for me, I think that they're essentially the same. So what this told me is that at least, again, this is not CLL or low-grade lymphoma, where we also use BTK inhibitors in some settings. But at least in this study, it suggested that there may be a difference in side effect profiles between the kind of next generation BTK inhibitors and things like ibrutinib. Again, take with a grain of salt, not a huge trial, but maybe a kind of an early look at how these drugs may play out when they all become available in a broader setting, for example, in CLL.
Yeah, no, certainly the toxicity profile of zanubrutinib is so much better, and for that reason also may end up being preferentially used. There is one question before I let you go, Nate.
Sure. I think I have one more study after this one.
You have one more study.
Yes.
So maybe we can take this offline. The question is on the MAGNIFY trial and the R-squared data in the context of AUGMENT and the relevance trial, relevance specifically where there was no statistical significance of adding in the REV in first-line treatment. Any comment on that? Because that is relevant, I think.
Yeah, so the relevance, just to remind people, I'll make it really fast. The relevance study was a randomized study looking at R chemo versus R squared. Relevance stood for Revlimid versus any chemotherapy relevance. And in that study, we enrolled over 1,000 patients in the front line and treated them with R squared or R chemo. And the trial was built as superiority, but we really saw almost identical outcomes between the two groups. The PFS was, I think, down to 1 point difference at 3 years, 79, I think it was 74 versus 73%. And the complete remission rate, overall response rate were also very similar. Again, a large trial showing really no difference in outcomes, clinical outcomes between the two groups. And when I see that, again, I'm obviously a little biased. If you see no difference, then the next thing you should do is look at adverse event rates. And there was significantly lower adverse events with regards to R squared compared to R chemo. Things like there was higher rash in the lenalidomide arm, but things like infections, febrile neutropenia, hospitalization due to infection, and neutropenia rate was almost double with R chemo, despite 3 times more growth factor use. So again, I think that both of these things are options, R chemo or R squared. In my mind, R squared is less toxic than R chemo, and it'll get you to the same endpoint. But yeah, that's my commentary on the relevance trial. I would, if we have time, I just wanted to show that one slide, that next slide. I'm not going to comment much on it. This is a Zuma trial. I just want people to stay tuned. And in the interest of time, I won't go through this. CAR T cells are coming to follicular lymphoma. There is a trial. This is the Zuma trial that will be going to the FDA and potentially will lead to FDA approval of CAR T cells for follicular lymphoma. Long duration of response, good overall response rate for CAR T cells. So stay tuned. I do think this trial could be the trial that gets these technologies into the hands of the community for low-grade lymphomas.
Okay. Thank you so much,
Thanks.
Nathan. Thanks for hanging out during your vacation. And
No problem. I'll hang out till the end. I'm happy. I love hearing this stuff.
Thanks so much. And without, we want to leave enough time for Dr. Dickinson, who's been patiently waiting.
Yes.
He has the most interesting piece on some of the novel agents in the non-Hodgkin's lymphoma space. So thank you, Michael, and it's all you.
Hi, everyone. So there's a clear need for new treatments in relapsed refractory non-Hodgkin lymphoma, and particularly the aggressive lymphomas, which represent a real therapeutic challenge because these diseases require treatments that can address the kinetic pace of the disease. The most common non-Hodgkin lymphomas occur in patients at a median age of between 60 and 70. And particularly in aggressive lymphomas, those who are included in clinical trials of relapse disease have had at least 2 prior therapies. And they're often a bit knocked about by the time they get onto clinical trials. And so this space requires treatments that are both aggressive but also tolerable. We've seen recently that we've seen recently that chimeric antigen receptor T cells have been a major development in this space, but the currently approved agents take several weeks to manufacture, require disease stability during manufacturing, and come with significant potential for toxicity, which can be unpredictable and at times severe. In addition, these treatments require significant resource utilization, which is a barrier to implementation. These are expensive treatments, but they require specialized multidisciplinary services and the capacity to deliver these treatments, such as intensive care and management of the more common complications of CAR-T, such as cytokine release syndrome and neurologic toxicity. So we'll go to the next slide. Over the last couple of meetings in lymphoma, we've seen more reports of this class of agents, the bispecific agents, and there's now a significant number of these molecules emerging in the field of diffuse large B-cell lymphoma and follicular lymphoma, which may prove competitive against chimeric antigen receptor T cells or provide treatment options for patients who aren't eligible for such therapies. The prototypic clinical agent is, of course, blinatumomab, which is approved in ALL and is a bispecific BiTE small molecule with a short half-life, which is delivered as an infusional regimen, and which didn't really show a lot of clinical activity in aggressive lymphomas so far, at least from what we've seen so far. And now we've seen the emergence of these new agents, such as this one, Epcoritamab, which was presented by Martin Hutchings at both ASCO and EHA, as well as others that have more favorable pharmacokinetic profile. So this one's a CD20-CD3 duobody developed by a company called Genmab. It's given it's given as a subcutaneous injection weekly for 8 weeks, and then alternate weekly for 3 months, and then monthly thereafter as a maintenance therapy until progression. And I guess the subcutaneous delivery of this agent may represent an advantage with respect to chair time and safety if other antibody therapies are anything to go by. So this trial included patients with relapsed diffuse large B-cell lymphoma and follicular lymphoma and escalated from low doses. And this is really just preliminary data that we've seen, very short follow-up. But as you can see in the panel on the left lower panel there, we're seeing very significant responses in the aggressive lymphomas, as well as everyone with follicular lymphoma having some kind of structural measured response. Importantly, only partial responses are recorded in follicular lymphoma, which may be due to underutilization of PET scans in evaluation of this patient cohort. At 3 of 14 patients with diffuse large B-cell lymphoma had a complete response. And in my view, in aggressive lymphomas, complete responses are particularly important. And so when I'm reading these studies of these bispecific agents in the aggressive lymphoma space, I look straight for the complete remissions, because I think these are the patients who appear to be least likely to progress. And I think that's something we've seen across all of these agents that particularly in aggressive lymphomas, it's nice to see complete remissions early. All of the bispecifics, and this is no exception, have pyrexia as a manifestation of cytokine release syndrome as a side effect. And here it occurred in, an acceptable level of 56% of patients. And it was grade 2 in 27% of patients, but it didn't become more severe, and no patients discontinued due to adverse events. And we didn't see very much of the neurotoxicity that we see with chimeric antigen receptor T cells so far, but very small numbers. It's worth keeping the overall response rate in mind when looking at this data. But we see here this kind of waterfall plot in follicular lymphoma seems to be replicated across the other competing agents in this space. So we'll go to the next slide. This brings us to some data which I presented at EHA on behalf of the co-authors of a drug called glofitamab, a significantly larger cohort of patients with a longer follow-up compared to the abstract as presented. Now, this is a full-length antibody which targets 2 CD20 molecules and 1 CD3 molecule. So it's what's been called this 2-to-1 format. And it has a long half-life, which means it can be delivered conveniently every 2 to 3 weeks. But it's delivered intravenously over a couple of hours in the chair. And here you can see that responses were achieved in all histological subtypes. This trial included a range of aggressive and indolent histologies, predominantly diffuse large B-cell lymphoma, transformed lymphoma, and follicular lymphoma. But we also had a smatterings of mantle cell lymphoma and Richter's syndrome and other lymphoma subtypes. But by and large, this was an aggressive lymphoma study. Most patients had aggressive lymphomas. And if you look at this waterfall plot overall, doses from 0.6 milligrams all the way up to 10 and 16 milligrams saw some structural responses, quite a remarkable waterfall plot. And again, in indolent lymphoma, pretty much every patient had a structural response. There were some exceptions, patients with CD20 negative disease that we saw some patients not have a striking response. Interestingly, these responses were achieved on the first or second response assessment. Cytokine release syndrome was the most common event, occurring around 56% of patients, and grade 3 or above in 5 patients. And only about 3% of patients discontinued treatment due to adverse events. And where this information was different from what had been presented so far was that we're now beginning to see the signs of durable remissions, as you can see in the bottom left panel. Just a reminder, this treatment's given as a fixed duration treatment, 8 to 12 cycles. So here we're seeing that you can stop these bispecific agents and actually see sustained remissions in aggressive histologies. It's relatively early days. We're still seeing a minority of patients followed up beyond 10 months. But again, quite interesting to see these sustained responses. So this is 2 of the bispecifics that have been developed. There are others that have been presented. Another drug called ANDROMEDA has been developed and presented by Regeneron, and I think there's going to be more and more data coming out here.
So I'm just going to stop you there for a minute, Michael, because, I think the lymphomas seem to have the same problem like the myelomas. Now you have CAR T-cell products in the same space targeting CD19, CD20. You have duo antibodies using the bispecific T-cell engager technology with really durable responses. How do you kind of see all of these pan out, and is there going to be a preferential one, or you're going to be thinking about the way we think about this in terms of sequencing and using it as bridges, etc.?
Well, look, I think it's too early yet to know if there's a sort of a winner out of the different agents. One of the questioners here has mentioned mosunetuzumab, and strikingly, Roche are actually developing 2 of these bispecific agents, very similar mechanism of action, same target diseases at the moment. So, I mean, I think we've got to see more mature data to know how these agents differentiate. But as I've mentioned, between the different bispecifics, they differentiate on route of delivery, frequency of delivery, and it appears that glofitamab probably has the edge in response rate in diffuse large B-cell lymphoma so far, acknowledging that I'm an author on that paper. But that it does appear to have a significant edge there in diffuse large B-cell lymphoma. How would I sequence them? Well, I think one thing about the bispecifics versus, say, CAR-Ts is that patient comes in, they need treatment, you just start it. Whereas CAR-Ts, you need to manufacture, wait for the autologous manufacturing to occur. So I think on the whole, the patients who are going into these clinical trials are, certainly in the case of glofitamab, I can speak with knowledge of this, a much less selected patient population than CAR-Ts. In terms of sequencing, I think with these durable remissions, I want to see more data at the therapeutic doses, keeping in mind that many patients here were treated below what we think is the optimal dose. But we may actually see outcomes that are comparable to CAR-T. And I don't see with those duration of response curves that there's a strong rationale for consolidating these treatments with CAR-Ts yet. And I also worry a little bit about the sequencing. So there's reason to believe that these antibodies might interfere with CAR-T manufacturing just on a sort of first principles basis. Although we have seen case reports of mosunetuzumab rescuing CAR-T failure and vice versa. For example, and we've certainly had clinical activity of glofitamab post-CAR-Ts here. I'd like to think that that they will compete with each other. That would be my hope, but I think the data are very early.
Great, thank you.
So my impression here is that we are seeing activity of these agents even in these aggressive histologies. It's very sort of promising so far, but still early days. I want to turn to another presentation from EHA, and this one's a little bit unusual because it's actually a retrospective study. So we'll go to the next slide. And this is a slide looking at REMIND, and it's really just to provide some contrast to these bispecifics about what's out there at the moment in the space of diffuse large B-cell lymphoma. And the LMIND study has very recently been published in Lancet, and the REMIND study was presented by Pierluigi Zinzani at EHA. And the goal of the REMIND study was to take the pivotal trial of tafasitamab and lenalidomide and then compare it to patients who were treated with lenalidomide alone. Now, tafasitamab is a CD19 targeting antibody, so it targets the same antigen as CAR-Ts. And it's given in combination with lenalidomide fortnightly out till 12 months of treatment, and then given as a maintenance treatment beyond that until progression. Now, importantly, in the LMIND study, this was quite a selected patient population. So patients could have had up to 3 prior therapies, but no more. And which differentiates this a little bit. And also patients with primary refractory diffuse large B-cell lymphoma were excluded from this clinical trial. So in my view, LMIND probably selected a slightly better patient group. These were considered to be patients who were ineligible for autologous stem cell transplantation. Nevertheless, we saw an impressive complete remission rate in this aggressive histology of 42%. partial remission rate of 17.5%, and an overall response rate of 60%. And the median duration of response in L-MIND was 21.7 months, really quite clinically significant in this patient population, and generally a well-tolerated treatment. So the authors of REMIND wanted to take a look, and they actually did a retrospective study of dozens and dozens of 480 patients from dozens of centres, pulled out data on patients who matched the inclusion criteria of L-MIND, did a matching exercise, and I think this is really just to build up their case for the combination. This doesn't, equate to a randomized clinical trial in my mind, but nevertheless, the data were interesting because the complete remission rate was several times higher for the combination of tafasitamab and lenalidomide in the prospective trial versus the retrospectively collected lenalidomide monotherapy, which had a best overall response rate of 34%. And there appeared to be a difference in survival, which approached statistical significance as well. So really, although this data that was presented at EHA isn't particularly, I think, going to change anything in and of itself, it does provide supportive evidence for the clinical benefit of adding tafasitamab to lenalidomide.
So given everything you have now for the high-grade as well as low-grade lymphomas, where do you think tafasitamab is going to fit into the treatment paradigm? Is there a role for this?
Yeah, look, I think there is a role. I mean, I think I go immediately back to the inclusion criteria. I mean, this was a trial that included transplant-ineligible patients and patients who didn't have primary refractory disease, and subgroup analyses suggest that the fewer lines of therapy that you had, the better that you did, which is not a surprise with this agent. So I think in terms of placing this versus polatuzumab vedotin, CAR-Ts and so forth, it's going to be about picking the right novel agent for the patient in front of you. And as you alluded to before, there are some issues around sequencing. So polatuzumab vedotin, for example, combined typically with bendamustine rituximab. Bendamustine not great prior to CAR-T cells. Lenalidomide, probably active after CAR-T cells, may build CAR-T cell activity. The addition of tafasitamab to that probably adds something, so that might be useful to explore in the post-CAR-T setting in CAR-T failures. And of course, again, TAFA and POLA and the bispecifics are all off the shelf, so treatments that can more easily be reached for. In terms of bridging, and this comes up very often, I think we just have to be a little careful about using anti-CD19 antibodies immediately prior to CD19 CARs. We have to be a little bit careful about exhausting T cells before we collect for manufacturing for CAR-Ts. We have to be a bit careful about using bendamustine before we collect for CAR-Ts. And I think all of those considerations are going to mean that we see a lot of treatment algorithms emerge for the different types of patients. And I think that's probably the best summary.
Yeah, no, that was a fantastic summary, Michael. Thank you so much. And thank you to the entire faculty. Time flies when you're talking about exciting things. We could spend another hour talking about all of this. But it just goes to show that there's so much of new and interesting stuff, and there's a lot of parallels between what's happening in the lymphoma world and the myeloma world. So thank you all for joining us this afternoon, and hopefully we will do more of these in the very near future. And thank you to Axiom for setting all of this up. Thank you all.
Great. Thank you, Dr.
Thanks very much.
Thanks, guys. See ya.
Thank you, Dr. Fowler. Thank you, Dr. Dickinson.
Bye. Thanks.
The videos will be available shortly, and we'll send it out to the folks that have registered. See you after ASH on a similar topic as well. Thank you again.
Terrific. Thanks very much.
Thank
Cheers.
you.